Welcome. I'm Dr. Cicek. Together with me, Dr. Sano, we will be moderating this session. And I regret that there would be a lot of cancellation and changes due to this recent corona outbreak, and the program is kind of messy now, and we will try our best to cover all talks. And there might be some changes with the titles. Please forgive us, because most of us were notified at the last minute to cover different topics. And however, I appreciate the help of my co-speakers on this session, and we will continue as much as possible and stick to the original program. The first session of the congenital postgraduate course is emergencies in congenital heart surgery, and the first speaker does not need any introduction. Dr. Sano is here, and he will be talking on post-operative emergencies, not TAPVR. So there's a misunderstanding with the communication. And the podium is yours, Dr. Sano, please.
Good morning, everyone. Because the lots of cancellation from AATS, so lots of topics are changed. And my initial topics was requested from AATS was the post-operative emergencies. I prepare this slide, so I do present this topic. No disclosure. So in 1960s, the post-operative assessment of after surgery was just only the vital signs and maybe the pressures, temperatures, and the blood gases, and took 1 or 2 hours. So, doesn't change. And then when I started the fellow in Green Lane in New Zealand, and in 1985-1987, the assessment in ICU was intracardiac lines, and RA lines, LA lines. At that time, no echo in ICU, and the blood tested the usual blood gases and the base excess. And then the 2005, when I was in Okayama, the assessment of after repair of tetralogy is a transesophageal echo, but it's not neonate and small babies and infant, bigger infant and children's. Intracardiac lines, sometimes we put LA and PA lines in marginal case. And the blood gas test is much quicker, but took 2 or 3 minutes. So the monitoring like this one, and we watched. And then the 2019, transesophageal Doppler echo become a routine evaluation. Sometimes after the hyperplastic, we open chest, and then the delayed sternal closure. Sometimes the patient needs ECMO or ECLA. And also recently, especially when you do an arch repair with antegrade cerebral perfusion or deep hypothalamic circulatory arrest, many unit or many ICU people use NRIS. So the outcome of pediatric surgery and the predictor of the major complications in developing countries, especially Indonesia. They present the paper very recently. The 257 patient made in age 36 months. Major complications occurred in almost 20% of the patients, and the cardiac arrest, need for emergency chest opening, and then the multiple organ failures. And the 30-day mortality was 13.6%. The lots of complications, the major complication to the surgeons, the bleeding, and the need for an emergency chest reopening, etc., etc. The deaths after the major complication is very high. So the post-operative emergency surgery is one is bleeding, the cardiac complications, of course, low cardiac output syndrome, and also residual lesions, residual shunt stenosis, valve stenosis, insufficiency, and then tamponade, arrhythmia, etc., etc. But these one is now much less common because of the routine use of intraoperative TEE. And once we found the residual lesions, we put on bypass again to repair. But still, some. This is for example. This patient is 16 years old male. He had a repair aortic LV tunnel in a neonatal period, and then developed a moderate to severe aortic regurgitation. He had a second operation, aortic valvuloplasty, but then again, initially the mild AV aortic insufficiency, and then developed the moderate to severe. So we did aortic valve replacement. The after repair by echo, you can see the huge effusion in the posterior wall. So that before the patient became tamponade, we did the pericardial drainage, and then the patient improved without major complications. This is another example, 4 days old male, the heterotaxy, the pulmonary atresia, unbalanced AV septal defect, the total veins. So one of our junior surgeons repaired total vein with a sutureless repair and the RBPA shunt, the 5 millimeter RBPA shunt, and the PA angioplasty using patient own pericardium, ductal ligation. The initial the cross count time was 72 minutes, which is not very long. But then after repair, TEE showed the AV valve regurgitation is moderate. So he put on bypass on the second one, and the cross clamp, and the AV valve repair. And after repair, the TEE showed still the moderate AV valve regurgitation. So he did the third run of the AV valve repair, and the post-op the TEE showed the common AV valve regurgitation become mild. So he finished the case, and the patient back to the ICU. And then the day 2, lactate increased to 6 to 9. So the ICU people increased the epi and dopamine and infusion blood albumin fluid to maintain blood pressures. And then suddenly heart rate dropped to 160 to 120, and the pressures up to mean pressure up to 40 millimeter mercury, and the patient become hypotension. And then the ICU people will start massage, and he asked our junior surgeon to come. And then the resuscitation, he put on the ECMO. And then day 7, the patient condition improved, so he decannulated the ECMO. But then again, the next day, the patient lactate increased, the hemodynamic become most unstable, so that he put on second ECMO due to LOS. And then 8 days after, the successfully decannulated ECMO. And then 38 days after surgery, delayed sternal closure. So this one is the result of some of the complications. If we do a much better way, then the patient may no need of these the ECMO twice. This patient is a very recent case, and 7 weeks of TGA multiple VSD coarc, and then the patient have a pneumonia before, so we waited a little bit, and then after the infection improved, we did the arterial switch, VSD closure, and the coarc repair, and then the open chest because of the long bypass time. The post-operative course was a little bit complicated. Here the chest X-ray, the right-hand side, there's a effusion. Goes. So so next day the patient have cardiac arrest in the morning, cardiac arrest due to tamponade. And also the patient have developed complete heart block, so press DDD pacing. And the day 8, the reason didn't recover, so the permanent pacemaker wires placed, and then the delayed sternal closure. So this is the chest X-ray. The post-operative day 17 still have like a heart failure. So we did the echo, and the echo showed the residual VSD and ASD, and pulmonary artery pressures and RV pressures increased. So we discussed, and then the cardiologist put a device to VSD to close, and then the atrial stenting in the cath lab, so that the patient little improved. But then again, after the device closure, we did the echo, and still a residual VSD. With the QPQS is 1.2, and so we think it's okay because they are just only 1.2. The shunt is not is mild, but then the patient have the infection again, and the right lung is collapsed, and then the abnormal shadow in the right lung, and then the arterial effusion from the right chest. These are the like a typical, or not typical, but it's the major complications after complex cases. This is the AATS ICU course. One of the question is the 3.2 kilogram TGA VSD repaired cardiac arrest in ICU 5 hours after heart surgery. What we do? The A is keep going resuscitation for 45 minutes And after 45 minutes, then it doesn't respond, then stop it. The B is keep going until assess the situation. C is prepare for emergency ECMO. D is open chest and start open CRP. And E is stop after 50 minutes of resuscitation, and the chance of survival is almost zero. So in the audience response was here. More than 70% of the ICU people said the open chest and start the open CPR. Some of them they prepare for emergency ECMO. And some of them probably very much similar, probably before going on ECMO, they assess the situation. And the ICU people are thinking. So the other question was how many bedside ICU emergency post-cardiotomy ECMO cannulation in your unit per year? The answer is less than or equal to 1. The B is 2 to 5 cases a year. C is 6 to 10. D is greater than 11 cases a year of ECMO. The answer is the 1/3 of the unit using the ECMO and 2 to 5 cases a year, and the 20% of the unit are using an ECMO greater than 11. So the STS congenital surgery database, out of 84,000 cases, operative mortality 3.4% in the STS database. Unplanned cardiac intervention was 5.6%, and then out of unplanned cardiac intervention, 60% of the cardiac reoperation, and 30% are the intervention, and both and 11. The common type of unplanned cardiac reoperation is like palliation, the shunt, and the banding. Because the quite common of the shunt occlusion in North American database. Although in Japanese database, the shunt complication is much less, but it's quite difficult to do. And then the pulmonary banding is not easy, especially in a complex neonatal small infant. Quite often need to tighten the band or to loosen the band. So the unplanned cardiac reoperation is more common in a neonate, and also the more common in complex cases. If you do the reoperation, unplanned cardiac reoperation in the cath lab, and also in OR, in both, the mortality is very high. The mortality is almost 33%. This is the data of the Pediatric Cardiac Critical Care Consortium. The bleeding required reoperation by centers, all surgeries in North America, is the average about 4 to 5%. Some of the unit are a little less, some of the unit is very high. And then the reoperation is the 2.6%, and the more common in the complex cases, start category number 5, and node procedures the 14, but the most common reoperation was the arterial switch plus VSD and arch repair. The majority, many of these patients have a bleeding and reoperate in the open chest, and more than 20% in the database. And the final one is the post-operative ECMO, and all procedures are here. Also, the number of ECMO is according to the unit. The node have more, the high percentage of ECMO. In UCSF, we use ECMO, but it's a little bit lower. Some of the unit routine use of ECMO, or I don't know, but the 2 units are using ECMO, almost all the patients. Here the ECMO set. In the aerosol registry, aerosol or ECMO registry in 2015, the cardiac one, the neonate survival and discharge also 41%. So what about my experience in Okayama? We have very bad result until the 2004, so we changed our policies of the ECMO since then. So we did like before, we put an ECMO. After cardiac arrest and the massage, we asked the perfusionist to set up the ECMO because the patient have no chance to recover. And then they set up 30, 40 minutes. Now the change. So before 30 cases, only 3 cases discharged. And after 2005 and before arrest, we put on ECMO. And then the dish separation from ECMO becomes 70% at the discharge, and the long-term survival 33%. That includes the cardiomyopathy patient. So the indication that changed before presence of end organ dysfunction or circulatory collapse, we do put an ECMO. If the patient need a high dose of inotropic support, we prefer to use the ECMO. So that the post-operative complications. Thank you very much.
Sunji, thank you. I have a question regarding the involvement of cardiac surgeons on intensive care units. Now, especially in North America, most of the intensive care is provided by intensivists, and which is for 24-hour coverage, which is something good, but this brings less involvement of surgeons in the intensive care unit and post-operative care of the patient. What is your experience and comment on involvement of surgeons, especially on training in intensive care?
And I think in Japan, we have very few specialist intensive care specialists. So the surgeons, they stay and they look after the patient. That's a very good training to the junior surgeons and the fellows, but it's a lot of an effort to them. In the UCSF, as you said, it's completely different. But the fortunate thing is now we have a very good fellows from India. He stayed almost every day in the hospital. I don't know when he will be back home. So whenever we have an emergency call and then go to the ICU, he's already there. But I'm sure that if he's not, he was back to India, I think we have lots of problems because the new guys came from also India, but he trained in Australia. He's quite often back home, and he will come from home. It takes like 20-30 minutes. So as we always discuss what to do, but it's quite often difficult to train young surgeons because of the in Japan too. Now the junior surgeons, the working time is limited. They need to go back, and so the learning chance is much less. We need to think of other things.
Any questions from audience? Sabura.
Thank you very much for your information about the emergency surgeries, post-operative. So sometimes, even I have a difficulty to decide back on or not. So after the surgery, together with the cardiac arrest. So, and my decision making is if the patient had more than 2 hours cardiac arrest, after that, if the transfer echo finding out some problem in the intercardiac repair, about the intercardiac repair, at that time, I will have one back home. However, after that, so usually ECMO with some problem is better to get the operation after backing the condition of the cardiac heart after the cardiac arrest, maybe so 5 days later, the operation, or back on again, 3rd time, 4 times. So how do you decide the back on during the operation, depending on the transfer echo?
No, transfer echo is a very nice tool. But it's a problem. All the decision is depend on the surgeons.
Yes.
Because the Mohan lady and my colleague quite often use ECMO, but he doesn't want to use the ECMO in OR.
Or
yeah, so he used a lot of the huge dose of almost every patient, and he preferred to use the AP and dopamine and no milrinone because he believed that the blood pressure dropped. My preference is not to use AP and dopamine, or the minimum of AP and the milrinone.
Yeah.
So it's taught different. And then the young surgeon who trained in Texas, the Texas is probably the post-operative management very similar to me, but also he trained in UCSF for a long time. So he is struggling which one is better. And then according to ECMO, quite often the intensivists prefer to put ECMO before the completely arrest and collapse. But it's quite often we start ECMO, but start arrest, resuscitation. At the same time, we set up the ECMO. So at the arrest, set up ECMO and put on ECMO is maybe usually within 30 minutes.
Yeah. So of course. But in the presentation, you had 2 times back home on the patient with experience together with the AV valve regurgitation, 2 times back home. And if the patient had the chance or possibility to have a third back home at that time, how do you decide? Again, the repair the common AV valve, or ECMO, and later diagnosis in the OR, and later trial to make a valve repair. Back home.
No, that's the different question and different decision. Because at that time I didn't assist him. He did operate with the fellows. So without me and without Mohan ladies. So he tried to repair, and then finally the cross-clamp time took a long time, more than 2 hours, 3 hours. So that yes.
Thank you.
The next topic is endocarditis in children. My co-chairman is C-Check from Mayo Clinic.
Good morning. I don't think endocarditis is a surgical emergency. However, endocarditis might be considered as an urgent situation, especially when we learn the outcome of earlier operations. And nothing to disclose, except that I decided to go back to Turkey soon to my previous program. What we know about infective endocarditis: it's an uncommon disease, and it is associated with significant morbidity and mortality. And with current climate, the profile of infective endocarditis is changing, and it's mostly more invasive species, especially staph species are overcoming the streptococcus species. But in contrast to many other developments in cardiac surgery, the mortality of infective endocarditis is still high. Luckily, it's a rare problem in a pediatric population. But with increasing number of surviving surgical patients, especially with congenital heart disease, and widespread use of NICU and PICUs, and significant increase in use of number of transcatheter devices and central catheters, the number of endocarditis in this group is also increasing. Interestingly, most of the recommendations for treatment of endocarditis were adopted from adult data and guidelines. Again, it is a rare association. The Toronto group from sick children published in 2018 their experience on infective endocarditis. Over 15,000 cardiovascular surgical procedures between 1978 and 2007 under the age of 18. Only 30 cases were undertaken for primary diagnosis of infective endocarditis, given an incidence of 0.2% for all surgical procedures. It's quite uncommon. However, it is important because it is still it carries still very high mortality and morbidity, and with the introduction of antimicrobial treatments and supportive therapy, the mortality decreased, early mortality decreased up to 1980s, but since 1980, we pretty much have the same high fatality rate, changing between 10 to 20% for infective endocarditis. What is a promising issue is early surgery provides survival advantage. This paper published in 2013 in Circulation reporting cumulative incidence and predictors of infective endocarditis in children with congenital heart disease. This is from Canada. As you might know, they have probably one of the best follow-up for all patients with congenital heart diseases, and over 47,518 children with congenital heart disease are followed over 450,000 patient years, and 185 cases of infective endocarditis were observed, and cumulative incidence is around 6.1 over 10,000 children with congenital heart disease. They also reported the predictors of infective endocarditis, and cardiac surgery within the last 6 months is the highest risk for developing endocarditis in children, as well as for congenital heart diseases. Cyanotic congenital heart disease is a significant association and carries significant risk for endocarditis. Interestingly, they also found that any patient with left-sided lesions and endocardial cushion defects has significant risk, carries significant risk for endocarditis, and I believe this should promote pediatric cardiologists and our group to reconsider the new endocarditis prophylaxis guidelines. And interestingly, again, operated patients with congenital heart disease have a significant risk for endocarditis. Congenital heart disease represents a significant difference between adult and pediatric populations for endocarditis. In adult patients, it's morely isolated valve disease or other problems, and congenital heart disease is rare except the group with adult congenital heart disease. This affects the epidemiology, treatment, and outcomes, and generalization of data from adult to pediatric population is again controversial. However, that's our best bet considering the small number of patients with endocarditis. Management depends on the prompt diagnosis. Diagnosis is one of the most critical issue, and with echocardiography and antimicrobial testing, prompt diagnosis of endocarditis is much more easier, as well as early institution of antimicrobial treatment is important. Staphylococcus species have become the leading cause, and these are invasive species causing a lot of problems. Decision making related to complications, including risk of embolism and need for and timing of high-risk surgery is important. Again, endocarditis is a disease that which should be cared by a multidisciplinary team. It's not a single specialty disease, and the group from French reported significant survival advantage at 1 year between the patients who were taken by a multidisciplinary treatment group, and now this became a class 1 indication on adult congenital on infective endocarditis guidelines, saying that patients with suspected infective endocarditis should ideally be cared for at centers with access to complete team, including cardiology, infectious disease, cardiac surgery, and other services needed to handle the infective endocarditis complications, especially neurology, neurosurgery, and radiology. What does surgeon need to know? At the time of surgery, the patient should be on effective antimicrobial treatment on correct dosage and route of administration to which the causative microorganism is sensitive or be broadly covered when organism and sensitivity are unknown. However, once the patient is on appropriate antibiotic treatment, waiting more for surgery, if there are indications, it will not be helpful. Keeping patients more on antibiotic treatment before surgery does not provide any survival advantage. Probably 3 to 5 days of antibiotic treatment would be enough before going with surgery if indications. The 2016 guidelines for endocarditis summarizes the indications for endocarditis. The major indication is signs of heart failure. Any patients who is appropriately treated with antibiotics and shows signs of heart failure, surgical intervention should strongly be considered. Even patients without signs of heart failure, however, has severe valvular dysfunction. I think there is no advantage waiting on more antimicrobial treatment, and these patients should be considered for earlier surgery, since we know that earlier surgery provides survival advantage. Any patients with prosthetic valve endocarditis is a patient who should be considered for low threshold for surgery. Any patient with invasion with paravalvular abscess or cardiac fistulas should be taken to surgery. Recurrent systemic embolization is an indication for surgery, and large mobile vegetations. This is kind of controversial, but depending on the valve site, large mobile vegetations that persist despite appropriate treatment is another indication for surgery. And persistent sepsis despite adequate antibiotic therapy for more than 5 to 7 days, this patient should be considered for surgery. The timing of surgery again is important. This was published by Melbourne group in 1995. The experience, summarizing their experience on infancy and childhood, and they clearly show that surgery provides significant survival advantage compared to non-surgical patients. Again, this is one of the largest series summarizing 21-year experience from Chicago group. They had 35 cases of endocarditis in 34 patients requiring surgical treatment, and there was a bimodal age distribution, which is important in children. There is a significant increase in number of endocarditis patients in the first year of life, and then after 15 years. Interestingly, valve replacement was performed in 22 patients. Most of the patients had a valve replacement and valve repair in only 10 patients, and the mortality was significant, 15% mortality. This is from Texas Children's Hospital. Their 15-year experience on 76 patients with a median age of 8.3 years. 46 patients, more than 60% required surgical intervention, and staph aureus was the most commonly isolated organism. Common surgical indications for them included severe valvular insufficiency, septic embolization, concomitant severe valvular insufficiency and ventricular dysfunction, which they recommended earlier surgery with severe valvular regurgitation even in the absence of any signs of heart failure. They were able to repair 50% of patients with native valve diseases. And they recommended early surgical intervention. And important group for endocarditis patients are patients who had an bovine jugular vein graft, Contegra graft implanted. We as surgeons noticed this much earlier than the cardiologist. However, Contegra has a significant risk factor for post-operative development of endocarditis, and especially this is probably most likely due to the treatment during the preparation for anti-calcification, denuding the endothelium. And this paper published by a group from Canada, and they reported 24 cases of endocarditis with bovine jugular conduits, and this is now a significant problem with transcatheter pulmonary valves, which they used bovine jugular vein graft. And again, the Texas groups reports that most of their patients who underwent surgery, native valve was tricuspid valve, and this was interesting. And Staphylococcus aureus infection has 4.7 times the risk for surgical procedure. Intervalvular fibrosa involvement is an important, and luckily we don't see this problem on children much. This is more of an adult problem, and however we see now increasing number of adult congenital heart disease patients with this problem, and almost 10% of the left-sided infective endocarditis have intervalvular fibrosa involvement, and 50% of patients with root abscesses have extension into the intervalvular fibrosa, and 25% of left-sided double valve involved the intervalvular fibrosa, and this is a very serious and significant problem which causes high preoperative mortality. This is from 801 patients from our group at Mayo, and long-term survival with multiple valves is dismal. What are the surgical principles? Preoperative imaging is very important. Transesophageal echocardiogram, transesophageal echocardiogram, CT, and MRI is needed before moving forward with any surgery, and especially if there are any neurological complications, the group from the neuroradiology should be involved with the decision making. And the most important part of the surgery is radical debridement of all impacted tissue. All the impacted tissue should be debrided completely. And I prefer to use some kind of formaldehyde solution, and different people uses betadine after radical debridement, but there is no shown advantage of using this kind of antimicrobials. And native valve in children should be preserved on all costs, and I try to use as much as possible autologous pericardium to repair these patients, and the valve again should be preserved. And after the radical debridement of the mitral valve here, and then put a pericardium there, and then use different kind of valvuloplasty techniques to provide competence. And luckily, with earlier operation, most of the valves could be repaired in children. If repair is not possible, prosthesis choice is an issue, and whether a given material offers a survival benefit still remains controversial. And this is more important in children because of the growth issues, but there's no survival advantage of any of the prostheses with regard to what you use. I just look over my own experience, 24 patients with endocarditis, and 14 of them operated within the 48 hours of hospital admission. 10 months to 17 years, 20 had congenital heart disease and no mortality. 6 of them had tricuspid valve endocarditis, 5 aortic, 8 mitral, and 5 of them VSD and conduit. And the surgical procedures, I managed to repair most of the patients. Mitral valve repaired in 8, tricuspid repaired in 6. Aortic valve repair is probably aortic valve repair is the most difficult repair, and it's on 2 patients. However, with now Ozaki procedure, I think there will be more chances to repair, especially with replacement of the partial leaflets, although it's a technically demanding procedure, replacing the partial leaflets instead of full leaflets. And 2 patients underwent Ross procedure and 5 patients underwent RVTPA conduit changes. Thank you very much.
Thank you, Sertak. Is there any question or discussion this topic? The one question is that you have no experience of or very few experience of the Contegra, or not Contegra,
Bovine jugular conduit, you mean?
No, what is the UCSF, or maybe in the United States, many interventionists put Melody valve.
Yeah, Melody.
In the conduit.
Yeah, Melody practically has bovine jugular valve conduit inside, and they have very significant number of endocarditis on that patients, and they come for reoperations.
But we have a very few experience in Istanbul of the infection of Melody valve. We were only 5.
I cannot say that, to be honest. I'm not. I have significant number of. Probably the Contegra was the most common valve I used when I was back in Istanbul, because it was more easily, before this transcatheter valves, it was more easily available. It was much cheaper than homographs, and I used over probably 100+ cases on Contegra. And our endocarditis cases with surgical patients are just 2 or 3 patients, not much. However, with transcatheter, to be honest, I don't have the numbers back there, but I think it's much higher than surgical.
Because when I moved to UCSF, the most of the intervention needs to set the rate of endocarditis after Melody valve 4 or 5%. But this is like 5 to 10 years, more than 10 years. The rate is increased. The recent report said it's 10, 15 years, almost 20%.
Yeah. That report, cardiologists report in very limitedly, and then 5% endocarditis on the transcatheter valves. That's not what I observed in the last 3 years, what I saw. It's much higher. It's minimum, close to probably 15-20%.
Okay, thanks. So we move to the next topics, the cyanotic newborn infant, Dr. Sakamoto, and he is the chief of the Shizuoka Children's, and also the president of Japanese Association of Pediatric Cardiology and Cardiac Surgery.
Thank you very much for your introduction. Me. Oh. Yeah, it's okay. So unfortunately, we are having a small meeting on the congenital heart surgery area, but we would like to make a good effort to activate this area. And my topic is emerging surgery in congenital heart disease on cyanotic newborns. So no disclosure there. As you know well, this slide showed the classification of the central cyanosis from the five causes: hemoglobin-related, metahemoglobin, like that, peripheral cyanosis, together with the LOS, peripheral cyanosis, and environment-related cyanosis, low oxygen, high altitude, and others. And most important central cyanosis for us, congenital area, respiratory function-related issue, and, of course, congenital heart surgery, congenital disease-related one. Anyway, respiratory function-related cyanosis is made by incomplete oxygen process of blood passing through the lung due to lung pathology, like collapsed lung, no change of the air, oxygen between the air and the blood. And alveolar disease, that's also. And the respiratory function related to desaturation of the patient with intrapulmonary shunt may improve with supplementing oxygen and positive pressure ventilation as it improves VQ mismatching. As you know well, we have to try make a better saturation, improve the saturation on the patient, even using this method. And this slide shows congenital heart disease-related cyanosis is made due to shunting of deoxygenated venous blood from the right side of the heart to the left side, systemic arterial circulation, leading to intracardiac shunt, so-called intracardiac shunt, including great vessel level, like that. 4 levels: venous levels, arterial level, ventricular level, and great artery level, including PDA. So we know well, so many diseases have cyanosis, and historically or usually we call 5T. CHDs with cyanosis require emergency surgery on newborns. 5T is TGA, truncus, TOF, and TAPVR and tricuspid atresia. But tricuspid atresia, so-called tricuspid atresia, is including univentricular physiology group because of the complete mixing in atrium and ventricle. Anyway, I would like to start the presentation on 5T, TGA. TGA has parallel circulation between the venous blood and the saturated blood from the pulmonary vein. And sometimes TGA has less blood mixing because of the no or restrictive atrial left to right shunt. These conditions make a life-threatening cyanosis with less mixing, together with or without low output syndrome to the systemic circulation and from normal to high pulmonary blood flow in TGA. Concerning the emergent approach, usually use infusion of prostaglandin to keep opening PDAs and balloon arterial septectomy by aggressive interventionist. And after that, we have to make arterial switch operation, surgical intervention. Before left ventricular pressure decreases, this is a standard course. As you know well, today, so we will have the, maybe today or tomorrow, I don't know exactly, we can get more information about the procedure or technique on arterial switch operation. So just information about the result. Arterial switch operation is reliable operation procedure with a reasonable result. Anyway, second is the TAPVR, total anomalous pulmonary venous return. And if the patient has obstruction on pulmonary venous drainage vein or less intra-arterial chanting from right side to left side, those make LOS, life-threatening cyanosis with almost all mixing with lung congestion. Not only bad mixing or chanting, with or without LOS, with low, from low to high. I don't know exactly, depends on the patient condition, pulmonary blood flow. Emergent approach is repair. It's simple. And conventionally, we use conventional repair to make anastomosis between the intimal to intimal anastomosis. And recently, we sometimes use primary sutures repair. And today, we had the possibility to get the information about the TAPVC PVO repair, TAPVC repair, but just a small information about the primary sutures repair from the Trump group. So Trump group made this information, 2011. At the time, he had a conventional repair group, 36, sutures repair, 21. And finally, no significant difference between two, but a potential to improve because or depending on the better 3D relationship between the pulmonary veins and the left atrium. Maybe so, together with conventional repair, some patients had the risk to distortion between the pulmonary veins and the left atrium because of suturing. However, primary sutures repair or suture repair itself have a less risk to make a 3D distortion between the pulmonary vein and the atrium. Anyway, so with or without sutures repair, the result of the TAPVC repair is improving with time. Now, even in my institute, almost zero mortality. And next one, TOF. Tetralogy follow is 1/3 of the tetralogy follow had clinical finding with cyanosis during neonatal period, from neonatal period. And if the neonate have severe pulmonary, with severe pulmonary stenosis or pulmonary atresia and closing PDA at the time, life-threatening cyanosis with low pulmonary blood flow and without usually LOS, but severe cyanosis. But those conditions is coming on around less than 10% of newborn with tetralogy follow. Emergent approaches is, of course, infusion of the prostaglandin. After that, surgical intracardiac repair is one of choice, but we are having the other choices. surgical intervention to increase pulmonary blood flow, including the aortic pulmonary shunt, RVOT reconstruction, partial conduit, or catheter intervention to increase the pulmonary blood flow, stenting on PDA, or stenting on RVOT. Some group have started to use the stenting on RVOT. And so this slide shows recent approaches in each area. United States, Canada group, European group, Japan group, not area, Japan, just Japan. So prostaglandin is the standard way to use as a first, not intervention, first therapy. However, Japan uses this prostaglandin infusion from several days to 1 month sometimes. But USA and Europe, usually within several days. And this one. Europe, early intracardiac repair is the first choice. And Japan, the first choice is palliation to increase the pulmonary blood flow. And less than 3 months, Japan has also tried to make a palliation to increase the pulmonary blood flow. Europe repair, USA mostly repair, sometimes palliation. After 3 months old, all the areas can choose repair. And catheter, stenting on PDA is in some area usual, and stenting on RVOT, some institute, and especially increasing in Southeast Asia, as you know well. In United States or Japan, maybe so less increasing about the stenting on RVOT or PDA. Anyway, this slide shows very interesting issues or information. So USA, Canada, Europe group try to make an intracardiac repair for TOF during neonatal period if the patient has severe clinical condition, 90% or 90%, or more than 95%. Japan is 65%. So palliation is one of the choice. But balance sparing rate, transarterial patch rate is this group a higher transarterial patch. I don't know exactly why, but maybe. So to make a balance sparing approach for neonatal very early infant, it is not so easy to do. So which is better? So very early, one stage intracardiac repair or surgical intervention or other catheter intervention to increase the pulmonary blood flow during the neonatal period. I don't know exactly. Anyway, another 5T, truncus. This group had severely high pulmonary blood flow without no obstruction to both lungs. And some patients had tricuspid valve stenosis and regurgitation, and some patients has interruption of the aortic arch. So, life-threatening congenital heart failure, LOS, with cyanosis, almost all mixing, and with severely high pulmonary blood flow, and LOS, and low coronary artery flow. That's the reason why the condition is very serious. And usual way is surgical one-stage repair with repair on truncal valve and interruption. This slide shows surgical one-stage repair, not classification, so called strategy. And as you know well, 7 years ago, so United Canada group reported this one from the review of the STS database. 95% have no tricuspid valve regurgitation, and result is good, or acceptable 9% mortality, hospital mortality. Not perfect, acceptable. And another one is if the patient has TR, TSR, or interruption at the time, more than 20%, and if the patient has require both truncal valve repair and repair of the interruption at the time, hospital mortality 80%, almost all patients die. So anyway, so under the background, so we consider, or many surgeons consider, try to make a surgical staged repair or not. In Japan, we recently, or from the 10 years ago, we sometimes use bilateral banding to control the pulmonary blood flow and at the same time, lower coronary pressure, increase the lower coronary pressure. And now some institute in Japan try to make a bilateral banding even on the patient without truncal valve repair and interruption, and with reasonable result. So less than 10%, less than 5%, or less than 3% mortality now. Anyway, so if the patient has severe truncal valve regurgitation, so even after PA banding, or to make a trial to make a intracardiac repair, we have to repair the bad truncal valve. This video shows the MEADS technique by me. The truncal valve condition is not so good, but not so bad. And the small valve and the four cusps, and so coronary ostium, left coronary ostium is here. So finally, I decided to translocate the coronary ostium and reject this valve to make me procedures. You can see this is one of choice. However, after this me procedure, truncal valve annular size is reduced because of rejection of the one cusp. So now, for me, we need to decide which better between the me procedure together with reduction of the annular size and other procedure that can keep the annular size. Anyway, so this one is made. So rejection, cut that and remove the valve and reconstruction of the annulus. Finally, like that, and translocation of the coronary ostium. That's all. Another choice is showing on this video. Leaflet extension strategy to repair the truncal valve. Yeah? Okay. This patient has abnormal coronary artery that make the course of the coronary artery is like that. So circulate around the lungs, around the annulus. So I decided it is not so easy to make a translocation of the coronary artery. So MEADS technique is difficult to do, and the leaflet condition on this patient is worse than the previous cases. And this one is very small, almost not so very bad condition. Anyway, So I decided to reject this one, and after that, make a leaflet reconstruction. Anyway, so this form, so like a Ozaki procedure, one cusp, and reject that, and make a leaflet using the autologous pericardium. So tanning time is around 3 to 5 minutes. Anyway, yeah, this one. So I did make a intracardiac repair after the valve repair. Anyway, this patient regurgitation before the operation is this one, and after almost controlled. So this patient had good early result. However, 2 years later, this patient had the reoperation on truncal valve together with the valve replacement. Anyway, last one is tricuspid atresia and univentricular physiology group. This one, life-threatening condition with cyanosis, almost all mixing with or without lung congestion sometimes. So this group cannot make fontanella-Graham procedure during neonatal period because of higher pulmonary vascular resistance during the neonatal period. So we have to adjust the pulmonary blood flow. Main PA bonding or bilateral bonding or aortic pulmonary shunt. And sometimes those patients have pulmonary venous obstruction, including HLHS with interrupted aortic. I showed a small video. The patient is a fetus of 37 weeks, HLHS, interrupted aortic septum. Maybe the patient had the bad seemed to have a bad result. So we decided to make an early surgical intervention to reject the atrial septum and the bilateral banding. So the other room, our gynecologist group had a cesarean section 9:49 and intubated 8 minutes later. The patient lung condition is very bad together with interrupted atrial septum. So umbilical catheter. So it was inserted by neonatology group, and later the patient moved to operative bed. Anyway, 42/3, and the saturation is less than 70, 65 to 65, and the operation was started 50 minutes after cesarean section. And we did make a ventricular fibrillation and aortotomy and ASD creation and bilateral banding, and finished the operation around 3 hours later from the cesarean section. This patient had a very acceptable course. Day 40, no type procedure, expansion, and discharge. And 9 months later, this patient got her bilateral Graham, and 1 year, 3 months old, 1 year, 6 months, 9.5 extracardiac TCPC. The patient condition was not so bad, even now. Anyway, on the group, univentricular physiology, palliative procedure to adjust the pulmonary blood flow is mandatory. However, some patients had difficult lung condition of PA growth level. So setting of the pulmonary blood flow to rescue the neonate with univentricular physiology is very difficult because of the natural higher PA resistance with both different lung condition and different PA growth. So I would like to show the aggressive PO flow adjustment on aortic pulmonary shunt. So banding with the bilateral banding is easy to do, make her readjust using a stitch. Anyway, after AP shunt in neonatal period, post-operative PVR rapidly changed with hours. So difficult to set the final appropriate state of PA blood flow in the operating room. So I decided to use graft size just or one size up because of the bad condition of the lung and others. And after that, adjusting PA blood flow by creeping like that on aortic palm shunt graft to get safer early post-operative course and delayed sternal closure. And after the patient condition is stabilized with days, de-adjust the PA flow again to get reasonable PA growth at delayed sternal closure, like that. So, take-home message. Even emergent surgery during neonatal period, many diseases with biventricular repair, biventricular can get good result with one-stage intracardiac repair with rather long cardiopulmonary bypass even now and cardiac arrest time. If the neonate has reasonable ventricle valve with acceptable repair and lung condition. On making palliative procedure to adjust the pulmonary blood flow on neonates, very careful setting is required because of many factors, including natural higher PA resistance with both different lung condition and different PA growth and others. However, together with accumulation to use palliative procedures, we have a possibility to make a better result using staged repair with palliative procedures than using historical or conventional one-stage repair, especially on truncus group. Thank you very much for your attention.
Thank you, Dr. Sakamoto. The very extensive review of all the diseases in neonate small infant. Is there any question? I have one question. In the United States, many surgeons do not like to do palliate, shunt.
I know.
Because the mortality is very high.
Yeah.
And whenever I said, they said, oh, Asian and American are different. There's no reason why the shunt mortality is very low in Japan database, and maybe like Asian countries compared to United States. But I said no different in the ratio. And that's why they prefer to do a complete primary total repair in every field, especially in the UCSF. The mortality of the shunt is very high.
Yes,
unfortunately. Quite often the arrest and the massage, adjust the PA flows, and put on the ECMO. It's not common, but it's a few times a year we have encountered these complications. That's why the repair truncus or the tetralogy and neonate, and then they put the homograft, like a 8 millimeter homograft or 10 millimeter homograft on small babies, and then within like 3-6 months time, the homografts become stenotic.
Yes.
The need to repair, redo again within 6 months, and then the second operation, and they still have like a homograft in a small one, and they need a redo conduit change in a couple of years. So lots of reoperations. So I quite often talk to them that why don't you do shunt? And then the shunt mortality, if the ICU management is okay, and also the surgeons have do a very good palliation, the mortality is not very high, very low. Yeah. And you can do a total repair and a little bit bigger, like 6 months or 9 months of age, and using a much bigger conduit, and also the intracardiac repair is more easy.
Yeah.
And posterior course more easy. But they still think, no, it's not only the Asian.
Yeah, that's the reason why I made this presentation. So together with the information about the adjustment of pulmonary blood flow during the neonatal period, maybe so Japanese institute had a trial to make a meticulous post-operative care from during the operating room by us surgeons. Sometimes so adjustment during the operating room by making a small clip and to control the easy and safe post-operative course from the operating room. I don't know exactly why, but so intracardiac one-stage repair, hearing attractive. That's the reason why, which is better. I don't know exactly now. Together with the better corridor pulmonary bypass and others, consideration of the information about the condition of lung and others. So, and another one is the valve repair technique during the neonatal period. If those issues is improving with time, at the time, again, we have to consider intracardiac one-stage repair. However, now, depending on the condition.
I hope that in the very near future, you create like an Asian database to show the result of shunt and others, compare the ASTS data in the European database.
Good comment to me. So now, so we are having the Asian Society for Pediatric Congenital Heart Surgery. So last year, I and other several persons founded that Asian Association. So we would like to inform to the world from the Asian data of the Asian data. So using the database in Asia, together with the world. Yeah.
Thank you, Dr.
Yeah, thank
Samura. Our last talk for this session is late presenting HLHS or ductal dependent lesions. Dr. Talwar will be presenting from India.
Pointer, please. Have a pointer. No. Have a pointer. Good morning, all of you. I thank the organizers for inviting me, and I try to keep this presentation as basic as possible because it is meant for the postgraduates. So I am Dr. Talwar from New Delhi, and I'll be talking to you about the late presenting hyperplastic left heart. So we all know that a duct-dependent circulation can affect the systemic circulation, the pulmonary circulation, and the systemic and the pulmonary circulation. So if it is there in the systemic circulation, we have the hyperplastic left heart syndrome, the critical aortic stenosis, and an interrupted arch. On the pulmonary side, it is the pulmonary atresia, the critical stenosis, pulmonary stenosis, tautology of Fallot, and tricuspid atresia. If there is a combination of systemic and pulmonary circulation, you have a TGA. The features of the circulation are, if there is a systemic circulation which is affected, then the infant presents with hypoxia and respiratory distress, severe heart failure, the absent femoral pulses, and severe metabolic acidosis. On the other hand, if the pulmonary circulation is affected, you have a condition of cyanosis, tachypnea, with normal femoral pulses, and there is no response to the hypoxia test. So by definition, the hyperplastic left heart syndrome is described as a condition in which the interventricular septum is intact and the left ventricle is hyperplastic. The biventricular repair is not possible, and there are basically 4 categories of the hypoplastic left heart syndrome. One is the aortic and mitral stenosis. Second is the aortic and mitral atresia. Then we have the aortic atresia and mitral stenosis, and then the aortic stenosis with the mitral atresia. And this is just a small chart for the postgraduates, and you can see here that the distal perfusion is via the patent duct arteriosus, the left ventricle is small, the mitral valve is closed or atretic, and the blood supply to the body is via the PDA. So the incidence among patients with congenital heart disease is around 5% or so, and 0.2 per 1,000 live births, and 25% of the deaths from congenital heart disease in the first week of life without any treatment, and 95% of them die within the first month without any treatment. So all those are left over would now be presented as the late hypoplastic left heart. So what are the determinants of survival in these patients? A large caliber PDA to ensure an unobstructed pathway to systemic circulation, the absence of obstruction to the pulmonary venous return in those who have got an intra-atrial septum and by an anomalous pulmonary venous drainage, and there is an adequate balance between the systemic and the pulmonary circulation and the resistance. So usually a typical hypoplastic left heart with an adequate ASD, you have an initial honeymoon period, but as the pulmonary vascular resistance tends to drop and the PDA closes, then there are severe symptoms because of the altered systemic perfusion. And then there is hypertension, acidosis, tachypnea, poor feeding, cyanosis, and cardiac failure. In 10% of the cases where the ASD is restrictive or the intra-atrial septum is restrictive, there is an incomplete mixing of the oxygenated and deoxygenated blood, and there is severe cyanosis and respiratory since birth and not after the honeymoon period, and they require the urgent creation of an intra-atrial communication for the survival. So the mortality in hypoplastic left heart syndrome, 15% die on the first day of life, 70% die within the first week of life, and 90% die within the 30 days. So what are the factors for unfavorable survival? One is the high PO2s, then the intra-atrial communication is small, the presence of mitral atresia, and then the presence of aortic atresia, then significant non-cardiac anomalies which these patients will often have. And usually these patients are diagnosed prenatally. That is most of the cases on antenatal ultrasound and all that, but there is a small proportion of patients who are not diagnosed in the neonatal period. So postnatal viability depends on the ductal patents. I'm again stressing on this because this is a true example of a ductus-dependent circulation. So when the QP and the QS are balanced, then the patient does not die, and the complete ductus of closure of ductus is incompatible with life in these patients, and it is fatal in the first few of life, with few exceptions which we previously discussed. So longest survival time without palliation is 3.5 years, and recently I came across a report in which patients survived for 22 years with a hypoplastic left heart syndrome and a large PDA. And this patient had systemic right ventricular systolic pressures with a normal and diastolic pressures. The PA pressure was equal to the descending aorta pressure, and there was low oxygen saturation in the aorta, which means a QPQS of less than 1, and the pulmonary vascular resistance was very, very high. So if you see the delayed hypoplastic left heart syndrome in childhood, now this patient is 7 years of age, has a big PDA, there is adequate retrograde coronary flow, an unrestricted pulmonary venous return, and no significant pulmonary vascular disease. And similarly, another case report of a 22-year-old patient was asymptomatic and had a similar kind of a picture, so then they were able to survive. So features of these patients who present late are dilatation and hypertrophy of the right ventricle, the hypoplasia of the left ventricle, the absence of the mitral valve, the aortic valve, the reduced mobility of the right ventricle, and hypoplasia of the ascending aorta. So standard management protocol for these patients. Now, when you talk of neonates, the normal stage 1 is the operation of choice, Then they go on to have a Glenn at 6 to 9 months of age, and then a Fontaine at 18 to 24 months of age. But what happens in the late hyperplastic left heart, rarely when the QP/QS is balanced, like if you have a 7-year-old patient or a 22-year-old patient, then the comfort care is considered to be the management of choice. You have a coarctation repair or pulmonary artery band and atrial septectomy after cath if the pulmonary vascular resistance is low, and if you do not have too much of arch hypoplasia, then the operation becomes a very big operation. The heart transplantation is preferred if there is severe or right ventricular hypertrophy, the development of the tricuspid regurgitation, a fixed elevated elevation of the pulmonary vascular resistance, and the policy, however, varies from an institute to institute and in the various setups. And the mortality and morbidity following the surgery is very high, and it can take the form of arrhythmias, coactations, dysfunction of the right ventricle, left pulmonary artery occlusion, and pulmonary artery hypertension. And then more than that, in the late presenters, the neurological complications are very common. The CNS abnormalities are detected in the postmortem specimens, and then they have the varying degrees of mental retardation and functional disabilities. So critical aortic stenosis accounts for 3 to 6% of the congenital heart disease. Again, it's one of the types of the hyperplastic left heart syndrome. The unicuspid aortic valve is most common. It has got a strong genetic basis, and some fetal aortic stenosis may progress to the hyperplastic left heart syndrome. And this is a cartoon which shows the severe aortic stenosis. And majority of the patients with severe valvular AS present with progressive congestive heart failure by 2 months of age. They're pale, mottled, hypotensive, and dyspneic. And the morphometric measurements will tell you whether these patients are going to be having the hyperplastic left heart syndrome or whether these patients are okay for a biventricular repair. So if you have an indexed aortic eminence of more than 3 centimeters per meter square, then you can think of a biventricular repair. And if you have a LV cross-sectional area of more than 2, again, these patients will be okay for a biventricular repair. And Rhodes et al. Have developed a predictive equation in which they talk of a discrimination score, and if it is more than 14, then again these patients can go for a biventricular repair. And they have the left ventricular score, which is a ratio of the long axis of the left ventricle to that of the heart, and that is a determinant of the biventricular repair in these patients. So what are the indications for intervention? The percutaneous balloon aortic valvuloplasty is recommended. These patients are very small, and the surgical options in these patients are limited to the Roscono operation because the mechanical valves for this age group are not available. And the indications are, again, if there is a presence of the severe symptoms, and then you find that if these children want to go for the competitive sports, then the surgery is recommended in the childhood. The interrupted aortic arch, we'll be talking about this more tomorrow. It is 1.5% of congenital heart disease. It's a complete discontinuity of the arch, and then the PD is again obligatory for survival, and the type B is the most common. So if you see the traditional classification of these types, the type A, when the arch is interrupted beyond the left subclavian artery, the type B, when it is between the common carotid and subclavian artery, and the type A, when it is interrupted before the origin of the innominate artery. And the associated lesions tend to be very common: the ventricoseptal defect, the truncus arteriosus, LVOT obstruction, which we will deal tomorrow, the valvular aortic stenosis, transposition of great arteries, DORV, AP window, you name it, and you have the associated lesion. And 60% of these patients have the DHR syndrome. Currently, the optimal timing of surgery in these patients is the first week of life, because otherwise you have the pulmonary overcirculation and reduced systemic perfusion, and a wide variety of techniques is employed, and that includes the end-to-end anastomosis between the ascending aorta and the descending aorta, the direct anastomosis of the descending aorta to the ascending aorta, and then augmented by a patch, and then a conduit interposition, which is rarely done in this smaller patients. It is only reserved for the larger patients in whom you cannot mobilize the aorta. The two-stage repair, if there are complex anomalies like you have VSD or a TJ or a single ventricle, then some people have documented the reduced mortality, the two-stage approach. However, in the current era, as we have been talking about since the last 2 presentations, the primary repair is a treatment of choice. Now, subaortic stenosis occurs in a significant proportion of patients with interrupted aortic arch. We'll be talking about this tomorrow. And there is a posterior deviation of the coronal septum, which morphologically can cause severe aortic stenosis, and this will be discussing in detail tomorrow. So associated management of this subaortic stenosis is a standard VSD closure. You ignore the subaortic stenosis, or it is a Norwood plus Rastelli or the SOE operation, in which the pulmonary artery is anastomosed to the aorta, and then you have a right ventricle to pulmonary artery conduit. So that is what is a SOE operation, which is another management for the interrupted aortic arch with subaortic stenosis. Now, the other thing is you can convert it into a single ventricle. You resect the coronal septum and apply a VSD patch to the left side of the coronal septum. And then after you have converted this to a one thing, the other thing is you could go for early primary repair, and all these things, the factors which you take are the timing of surgery, methods of heart and brain protection, aortic arch repair, truncal valve repair, as well as the right ventricle to pulmonary artery continuity. This is all debatable, and various centers which tackle these things in different ways. Now, interrupted aortic arch with a single ventricle, so initial PA band with Glenn or Fontaine, and along with the arch repair is an option. The problems are that the pulmonary artery band can migrate, and there can be the aggravation of subaortic stenosis. So some would argue for, rather than a PA band, the enlargement of the bulboventricular foramen, or resection or enlargement of the VSD, a big atrial septostomy, and the repair of the interrupted arch in these patients. And then the other option is the Norwood procedure, because then it can take care of the obstruction at all the levels and also provide a source of the pulmonary blood flow. And the re-interventions after the arch repair are restenosis of the aortic arch, the branch pulmonary artery stenosis, the bronchial stenosis because you mobilized the aorta to a great degree, and the recurrent subaortic stenosis, and a few variety of other complications. Now, if you talk of the VSD pulmonary atresia, which is actually not the subject of this talk, because it is a ductal dependent lesions, that will why I will just mention it in passing. It is almost 3% of all congenital heart disease. It's the most severe form of tetralogy, and 20 to 40% have major aortopulmonary collaterals, which act as the source of the pulmonary blood flow. And the management of these patients consists of unifocalization of all the MAPCAs, which could be staged or which could be one stage. You rehabilitate the pulmonary arteries and promote the growth of the native PAs. And somewhere down the line, you place a systemic to pulmonary artery shunt, insertion of the main pulmonary artery to the aorta is another option, and ultimately the right ventricle to the pulmonary artery connection. Now, critical pulmonary stenosis is 10% of all congenital heart disease. 60% of these patients will require the intervention due to cyanosis, and the only thing which will keep them alive is the PDA. And the RV hypertrophy or hypoplasia, which means a poorly compliant right ventricle, which demands an intervention. So treatment of choice is the balloon valvuloplasty, and the rate of failure to cross the pulmonary valve and achieve this is close to 5 to 10%, when these patients will actually then require a transannular patch. And the residual gradients of 20 to 25 millimeter mercury from the RV body are very common following this approach. So tricuspid atresia is again a condition which is 1% of all congenital heart disease. It can be ductal dependent if there is a severely restrictive intra-atrial septum. 50% are diagnosed on the first day of life, 85% within the 2 months, and 50% have got cyanotic spells, and 12% have got CHF in infancy. And the restrictive is ASD in 5% of these patients, and these patients may be then dependent only on the PDA for the systemic perfusion. And then 50% of the patients will die within the 6 months of life. Only the 1/3 of the patients will survive, and less than 10% alive by the age of 10 years. So TGA with PDA is again another lesion in which the reverse differential cyanosis in TGA occurs in PDA and pulmonary arterial hypertension. Again, the PDA is something which is ensuring the mixing and helping the patient survive. So key to survival in the ductal dependent lesion is to realize that the patient is duct dependent. So early recognition of these reasons and interventions which address the basic diagnosis and the PDA will lead to the patient having an optimal survival. Thank you very much. This is my institute, and all of you are please requested to block your dates for the World Society of Pediatric and Congenital Heart Surgery meeting, which takes place in New Delhi from September 17th to 20th this year. Thank you very much.
Dr. Talwar, thank you. Excellent presentation. Any questions from the audience?
The topic is like the late presenting hyperplast. If you have a patient and the hyperplast and referred to you 2 or 3 weeks of age, what do you do? What do you think?
One of the things that is common in India is a late diagnosis and referral. So it is not uncommon for us to have the patients to be referred to us as late. So if we have a patient of 2 to 3 weeks of age and we are able to establish that the pulmonary vascular resistance is not very high and patient has got adequate systemic perfusion, we would stabilize for maybe 3 or 4 days and then proceed to a conventional Norwood operation, because we don't want to maintain the high PaO2 in all these patients. So that is the usual protocol in our patients, to proceed with the standard Norwood operation, unless you have somebody like 1 or 2 years presenting with this. The other thing which we want to rule out is what is the type of the ascending aorta and the arch and the status of the coarctation. Now, if you have just a hyperplastic left heart syndrome and the presence of a coarctation and let us say the intra-atrial septum is not restrictive, you would probably go for the management of the standard coarctation repair from the side. However, if there is a significant hypoplasia of the arch and the aortic and the mitral aortic valve is not atretic and there is adequate coronary perfusion, you would just go ahead and do an atrial septectomy along with a standard Norwood operation. So the anatomy would dictate many times the approach to these patients, because it is a very heterogeneous subset.
Because I think in most of the centers in the United States and Japan, the patient are diagnosed in the fetal echo.
Yes.
So we almost all the patients know the patient delivered like tomorrow is the hyperplast, and they quite often these patients have developed like a heart failure because of excessive blood flow within a few days. So to me, if the patient is stable and alive in 2 weeks and 3 weeks, that means the ASD or PFO is relatively small, restrictive. Once you do, some of the papers from the pathology show these patients with intact atrial septum, restrictive ASD, the pulmonary veins diameter is very, very small compared to normal children. That's why many surgeons and the intensivists misunderstanding that, we have like the total repair with the hyperplast in the intact atrial septum, restrictive ASD, and post-operative course was very stable. To me, the very stable means the pulmonary vascular resistance is high, because the most of the unstable situation is a high flow.
It's because one of the reasons for the patients coming late to you.
Yeah, so to me, and if I have like this patient, probably better to have like a balloon dilatation of the and create a bigger ASD, and then put a band, and then wait for like 2 or 3 weeks.
Yes.
Like a rapid 2-stage. Possible?
One of the things which I wanted to highlight here was that in India almost no hyperplastic is diagnosed before birth, because the antenatal echo facilities are not available and they're only located to very big institutes. So patients do get referred late, 2 weeks, 3 weeks, even as longer as a month. So they have some reason which is keeping them alive. And probably you need to take care of that component, like as you said, do an atrial septectomy. And if you have a definite coarctation, and a big coarctation needs to be taken care of, and then many times the ascending aorta in these patients will be okay, because see, when these patients present late, the anatomy is not so bad. So many things you can address. If they have a big ASD, a simple band and a simple coarctation repair is enough. Sometimes the ASD is also big, or you can have subtox with a simple coarctation with a pulmonary artery band is okay. So it will depend on the anatomy of the patients.
These patients survive, but from our experience in UCSF, we have two patients waiting for transplant. They're both hyperplastic interrupted aortic septum. Even if the patient survived, then it's not a good candidate of grain. If it's okay, one patient had a grain, and then they fontan and take it down.
These late presenters will often have a regurgitation of the tricuspid valve and the right ventricular dysfunction. So that rules out the engineering on the heart. And then they have the high pulmonary resistance, so they will ultimately become the candidates for transplant. Because left ventricle is absent, the only valve, which is a tricuspid valve, is a systemic AV valve. So these patients are not going to survive without that. So they are listed for a transplant. But the problem in that is you're getting hearts for these smaller patients. So most of the time, the patients in India are at least left to comfort care. The other problem with hyperplas in India is many times the patients, the relatives of the patients are not ready to undergo all the 3 steps of the operation. They would not be mentally ready. So there is a 50 to 60% dropout, and the people do not elect for the first stage.
Thank you, Dr. Talwar. We'll take 20 minutes and we'll start at 10:45 exactly for the next session. And we thank all the participants and speakers for this excellent session. Thank you.
It's okay.